Hello and welcome to my channel. In this lecture I will be discussing the musculature of the shoulder region. So let's begin. The muscles of the upper limb in general grouped as follows: the muscles connecting the upper limb with the vertebral column, muscles connecting the upper limb with the thoracic wall, muscles of scapula or scapular muscles, arm muscles, forearm muscles, and hand muscles. This is the plan we will go by in discussing the upper limb. The muscles connecting the upper limb with the vertebral column, first is the trapezius muscle, the one you see here. It has a very wide origin. It's triangular in shape, as you can see here. From the superior nuchal line, the external occipital protuberance, and the ligamentum nuchae, and C7 spine, and all thoracic spines, and supraspinous ligament. All this is the origin for the trapezius. So you can divide the fibers of the trapezius into superior fibers, descending fibers, and middle fibers, transverse fibers, and inferior fibers or ascending fibers. The upper fibers descend to the posterior border of the lateral third of the clavicle. The middle fibers are horizontal to the medial side of the acromion and superior lip of the spine of the scapula. Okay, these are the middle fibers. The lower fibers or the ascending fibers to medial end of the scapular spine. So these are the lower fibers, the middle fibers, and the upper fibers. It's called trapezius because both muscles together form a trapezium. See? A trapezium. There's an aponeurosis in the middle of the muscle along the lower cervical and the upper thoracic spines. The aponeurosis you can see here. And the action of the muscle, it elevates the shoulder or shrugging of the shoulders. And this is how to test for the trapezius, to shrug the shoulder against resistance. And with serratus anterior, it rotates the scapula by pulling this way. The serratus pulling that way, it will rotate the scapula in raising the arm. The raising of the arm doesn't involve only abduction to 90 or 100 degrees or so. Then the rest is by rotation of the scapula. And together with rhomboids, it can retract the scapula. The nerve supply of the trapezius, as you can see here, this is the spinal accessory nerve, and also C3 and 4 for proprioception, fibers coming from the muscle spindles and Golgi tendon organs of the muscle. The Latissimus dorsi muscle arise from the lower 6 to 7 thoracic spines and supraspinous ligament, or lumbar and sacral spines by the thoracolumbar fascia, as you can see here. This is the muscle in whole. This is the Latissimus dorsi. Arises also from the iliac crest, lower down from the iliac crest. Okay, from the iliac crest, as you can see here. And from the lower scapula, inferior angle of scapula, it curves anteriorly to be attached in the floor of the bicipital groove between the pectoralis major and the teres major. The upper fibers are horizontal, the middle fibers are oblique, and the lower fibers are almost vertical. Now, if you observe here, this is called the auscultatory triangle between the trapezius, the upper border of the latissimus, and the medial border of the scapula. The floor is the rhomboids major and minor, mainly the major muscle. This is where you can hear the lungs and the heart best because, lesser layers. It's only the rhomboids and the thoracic cage. Also down there, it forms another triangle back border of the external oblique, anterior border of the latissimus dorsi and the iliac crest. This is the lumbar triangle. The floor is formed by the internal oblique muscle. This is a site for a rare hernia. This is a site for rare hernia. Now, the action of the latissimus is adduction, medial rotation, and extension at the shoulder joint. But let me ask you a question. Adduction of the upper limb. The upper limb is already adducted by gravity. Okay? Why do we need this huge muscle to adduct the upper limb? This is the question here. Actually, it's not adducting the upper limb. It's adducting the body to the upper limb. This is the muscle you use in climbing. You know, in climbing, in swimming. That's why it has this wide origin to have a firm grip on the body when doing such activities like swimming and climbing. The nerve supply is by the thoracodorsal nerve or nerve to latissimus dorsi, C6, 7, and 8. Rhomboids, major and minor muscles. The rhomboid major and minor muscles, this is the rhomboidus major and this is the rhomboidus minor. From the medial border of the scapula, the rhomboidus minor arises from the area adjacent to the root of the spine of the scapula, and the rhomboidus major from the area below the medial or vertebral border of the scapula. They insert, this is the insertion, the origin from the rhomboidus major from T2 to T5, thoracic 2 to thoracic 5, spines and supraspinous ligament. The rhomboidus minor from spines of C7 and T1. What do? They retract the scapula. Okay, they retract the scapula, and the nerve supply by the dorsal scapular nerve, the one we studied in the head and neck, or nerve to rhomboids, it's C5. Levator scapulae muscle, also we studied this in the neck. It arises by multi-heads, as you can see here, from the posterior tubercles of the transverse processes of C1 through 4, C1, 2, 3, 4, and inserts in the superior angle of the scapula. This is the levator scapulae muscle, and its nerve action to elevate the scapula by its name, and the nerve supply dorsal scapular nerve and bidirect branches from C3 and 4 ventral rami of the cervical plexus. Okay, muscles connecting the upper limb to the thoracic wall. Let's talk about the fascia a little bit. The superficial fascia of the pectoral region continues with that of neck, upper limb, and the abdomen. Contains the mammary gland, as you can see here, with these ligaments, radial ligaments, the suspensory ligaments that divides the mammary gland into lobes. Okay, the pectoral fascia on the pectoralis major continues with the axillary fascia, and deep to pectoralis major it continues above with the clavipectoral fascia you can see here, and in the axilla as the suspensory ligament of the axilla. The clavipectoral fascia is a continuation of the deep investing layer of the skin after it traversed the clavicle and enclosed the subclavius, and then it will enclose the pectoralis minor as well. This is the clavipectoral fascia, and pierced by the cephalic vein on its way to the axillary vein, the thoracoacromial vessels, and the lateral pectoral nerve. These are the structures that pierce the clavipectoral fascia. It's anterior to axillary nerve and vessels. Okay, pectoralis major. This is the pectoralis major muscle. It has a clavicular head from the medial anterior surface of the medial half of the clavicle. From the anterior surface of the sternum, this is the sternal head. From the upper 6 costal cartilages, this is the costal head. Also, it takes from the aponeurosis of the external oblique muscle. The fibers converge laterally, see, and they are twisted. Inserted in the lateral lip of the bicipital groove, and you can notice here that the lower fibers are highest and the upper fibers are lowest in their insertion into, it's a bilaminar tendon, into the lateral lip of the bicipital groove. Okay, did I say linea aspera before? If I did, I'm sorry. The bicipital groove, the lateral lip of the bicipital groove. Relations anteriorly related to skin, fascia, platysma, mammary gland, and supraclavicular nerves. Remember the supraclavicular nerves coming from the cervical plexus, C2, 3, and 4. C3 and 4 and 5. They are arranged in groups: the lateral group, the intermediate group, and the medial group. Posteriorly, the muscle is related to the thoracic wall, the axillary vessels and nerve, and the pectoralis minor muscle. Once you remove the muscle, you will find the pectoralis minor. Superiorly, it forms a groove with the deltoid. It's called the deltopectoral groove with the cephalic vein in it. The cephalic vein in this groove, and the deltoid branch of the thoracoacromial artery as well, running in this groove. It's obvious here. See, it's clear here, the deltopectoral groove. The action of the pectoralis major, because it passes anterior to the shoulder joint axis, so it's adduction, medial rotation, and flexion at the shoulder joint. Adduction, medial rotation, and flexion. The nerve supply is by medial and lateral pectoral nerves. The nerves supply the muscle from the deep side. Pectoralis minor muscle, see, this is the pectoralis minor muscle, takes from the bone, not the cartilages, of rib 3, 4, and 5, as you can see here. Rib 3, 4, and 5, bone, not cartilage. This is a multiple choice question. Inserts in the medial border of the coracoid process. So by its direction, it protracts the shoulder region by pulling on the scapula, pulling it forward. The medial pectoral nerve pierces the muscle and supply and ends in the pectoralis major. The lateral pectoral nerve and the pectoral branch of the thoracoacromial artery are along the superior border. The lateral thoracic artery along the inferior border, and the clavipectoral fascia, the one you see here, above it. The action of the muscle is to stabilize the scapula and protracts the scapula. Nerve supply by the medial pectoral nerve. This is the pectoralis minor. The subclavius muscle. Subclavius muscle arises, see, from the costal cartilage of rib 1 and inserts in a groove on the undersurface of the inferior surface of the clavicle. This is the subclavius muscle. Subclavian vessels and brachial plexus separated from the first rib, and the action, it steadies the clavicle during the movements of the upper limb. It steadies or fixes the clavicle to, decrease the strain on the sternoclavicular joint. The nerve supply by the nerve to subclavius of C5. Serratus anterior muscle. All this is the serratus anterior muscle, arises by digitations from the outer surface of the upper 8 ribs, inserts into the anterior surface of the medial border of the scapula. Lower 4 digitations interdigitate with the digitations of the external oblique. See, This is the external oblique digitations, and this is the serratus anterior digitations. Forms the medial wall of the axilla. Medial wall of the axilla formed by the serratus anterior. The action, pull on the muscle, you will protract the scapula, like, you know, in punching someone, like in swimming, in boxing, in swimming. It brings the scapula forwards around the thoracic cage. Okay, and with the trapezius, by its pull, with the trapezius, it rotates the scapula. The trapezius is pulling this direction, and the serratus anterior pulling in this direction, so it rotates the scapula. Well, when do we need to rotate the scapula? In abduction, in raising the arm. Okay? The nerve supply is by the long thoracic nerve, or nerve to serratus anterior, C5, 6, 7. And the paralysis of this muscle, you can test for it by asking the patient to lean with his hands on the wall and observe the back. You will see winging of the scapula because the serratus anterior is paralyzed. This is how to test for the serratus anterior or for the long thoracic nerve, C5, 6, and 7. The scapular muscles, we have the deltoid muscle. It's a triangular multipinnate muscle. This is the deltoid muscle. And see how it's inserted in the V-shaped deltoid groove on the humerus. It has posterior fibers, middle fibers, and anterior fibers. Anterior, posterior, and middle fibers. The anterior fibers arise from the anterior surface of the lateral third of clavicle. The middle fibers from the lateral and superior aspect of acromion. The posterior fibers from the inferior lip of the spine of the scapula. Inserts in the deltoid tuberosity on the lateral surface of shaft of humerus, and it gives the contour of the shoulder. And you examine it. You examine both shoulders for their contour if you suspect malnutrition in a patient. Remember, we said that about the vastus medialis as well. The anterior border forms the deltopectoral groove, the one we saw earlier with the pectoralis major. Posterior border is on the triceps and infraspinatus muscle. Deep are the scapular muscles, the coracoid process, and muscles attached to it, like coracobrachialis and pectoralis minor, axillary nerve and circumflex humeral vessels. Superficial are skin, fascia, platysma, lateral group of supraclavicular nerves, and upper lateral cutaneous nerve of the arm. Upper lateral cutaneous nerve of the arm. See? This nerve, this cutaneous nerve, upper lateral cutaneous nerve of the arm. Action of the deltoid: anterior fibers flexion at the shoulder joint, middle fibers abduction at the shoulder joint, posterior fibers extension at the shoulder joint. The nerve supply is by axillary nerve C5 and 6, mainly C5. The subscapularis muscle, all this is the subscapularis muscle. It's a multipinnate muscle, arises from the medial 2/3 of the subscapular fossa and inserts in the lesser tuberosity of the humerus and blend with the shoulder joint capsule. Remember the rotator cuff muscles we discussed in the shoulder joint? This is one of them, the subscapularis muscle. A bursa between the muscle and bone, and it forms the posterior axillary wall. It forms the posterior wall of the axilla, and the action is adduction, medial rotation at the shoulder joint. The nerve supply by upper and lower subscapular nerves from the brachial plexus, from the posterior cord of the brachial plexus. It's C5 and C6. Supraspinatus muscle arise from the medial surface of supraspinous fossa, pass under the acromion, and there is a bursa between it and the acromion, to the tip of the greater tuberosity and fuses with the capsule of shoulder joint. So it's one of the rotator cuff muscles. You examine for lesions in the bursitis of the bursa between the supraspinatus and acromion, the subacromial bursa, by asking the patient to abduct the arm. He will experience pain, especially in the initiation of abduction. The action, it initiates the first 15 degrees of abduction at shoulder, and since the nerve supply is not axillary like the deltoid, so lesion of the axillary does not completely eliminate abduction at the shoulder, because there is still a degree of abduction because of the supraspinatus. The infraspinatus muscle from the medial 2/3 of the infraspinous fossa below the spine of the scapula usually blends with the teres minor, as in the case here. This is the teres minor muscle. The infraspinatus goes to the back of the greater tuberosity and fuse with the capsule of the shoulder joint, so it's one of the rotator cuff muscles. Action is abduction, lateral rotation at shoulder joint, and nerve supply by the suprascapular nerve. The teres minor muscle, the one you see here, arises from the lateral border of the scapula, inserts in facet below the facet for infraspinatus on the back of the greater tuberosity, and fuses also with the capsule, so it's one of the rotator cuff muscles. Action of the teres minor is lateral rotation at the shoulder joint. Nerve supply like the deltoid by axillary nerve, the teres minor muscle. Don't confuse that with the teres major muscle, which is attached to the inferior dorsum of the inferior angle of the scapula and goes to the lateral and lower part of the lateral border of scapula and inserts in the medial lip of the bicipital groove. So it has to, curve anteriorly. It goes anteriorly. That's why it passes in front of the axis of the shoulder joint. So it will produce medial rotation, not lateral rotation, like the teres minor. Medial rotation at the shoulder joint, adduction at the shoulder joint, and extension at the shoulder joint. The nerve supply is by lower subscapular nerve. Okay? This is the musculature of the shoulder region. I hope you got the maximum benefit from this lecture, and thank you very much for watching.